I'm pleased to welcome Joy Schmidt from Dane County Adult Protective Services. Joy specializes in dementia care when someone's in crisis, right? And she's in charge of the program here in Dane County.
Hello. I recognize some familiar faces, and it's nice to be with you today. I wish we were in person. That's always better, but Zoom definitely saves time. As Mike mentioned, I work for Dane County within Adult Protective Services. This is a new role that started in 2020. My first day was actually the day the county went remotely because of the pandemic. It's been an interesting experience as we've tried to create what this position would really look like. So my contact information, once I put up my screen share, here I'll go ahead and do that. How does that look?
Excellent, Joy. We can see it.
Great. Yeah. So here's my contact information. So my background is I have a degree in social work from Indiana University. And then I've just been working with older adults my whole career since I started in this as a volunteer when I was 18. But then working in various different capacities in facility care, memory care, senior centers, and the Alzheimer's Dementia Alliance, and then as the dementia care specialist for the ADRC before moving into this position. And so part of the challenge, and as preparing for this, we never know who's going to be in the audience and how much you already know about dementia. So I will touch on just some really basics about dementia itself. But part of the conundrum that we are dealing with in Wisconsin is that there just really aren't resources for folks who end up really in a crisis situation. And what we think of crisis is a person who is having, issues, behavioral issues potentially that are causing them to be a threat to themselves or a threat to others, and maybe causing a situation that is just really unsafe. Some well-meaning advocates, probably 13 years, 14 years ago now, decided that people with dementia should not be in psychiatric hospitals. And so a law came into effect that prevents people in Wisconsin from being involuntarily detained in a psychiatric hospital. And because the law indicated that, these folks have dementia and it's not a treatable mental illness, so they don't belong in a psychiatric hospital. And this is all well and good, and many times we do support this. But there are times where folks have comorbidities, they have additional issues that they're facing, and we don't have alternative options for them. So today we'll be talking. I did want to present that because Mike thought that would be helpful. I'll try to have time for questions. But our goal is always to try to be preventative in our supports of individuals and to try to help situations stabilize in place whenever possible. But again, there aren't always good alternatives. And sometimes people end up just having to be in the general hospital and not receiving really the specific care. So today, again, we'll touch on what is dementia in case there's folks in the room who aren't familiar with that. And then talk about some of the proactive things that we can try to do, and then preparing for a crisis. And a piece of this is also remembering that family members can, and primary caregivers frequently become so integral. This is such an important part of dementia care, is also serving the families and the primary caregivers. But if they go into a crisis situation, have a medical situation, what's the plan for that person with dementia that has relied on that individual? So, all right, moving forward, let's see if I can, there we go. Okay, just a quick pause to make sure sound is okay. And
Sounds good to me, Joy. When do you
okay.
want to take questions? Yeah, as they come up or at the end?
Okay, as they come up is fine. Yeah.
Okay, so everyone, if you have a question for Joy, just unmute yourself and jump in. Thanks.
Or put it in the chat, whichever you're comfortable with. Okay. So what is dementia? Dementia is a general term that describes a set of symptoms. There can be confusion about that. Sometimes doctors are still just saying it's dementia because it, to diagnose Alzheimer's, to diagnose some of the other conditions, it's always still a probable condition that they might diagnose a person with. So it can take a number of tests. A lot of times it's ruling out other conditions and kind of looking at the familial genetic side of things to try to determine a diagnosis, but also looking at other factors. And so again, dementia is a general term. We continue to use it routinely, but it's not the typical diagnosis. Instead, that is neurocognitive disorder is what it's oftentimes called now, because that's what the DSM has listed the diagnosis as. So the changes can include memory loss, changes in judgment, personality, and decision-making, to name a few. But these are diseases of the brain. And so anything that the brain controls, it can affect all those things. There's more and more in the news about vision changes, kind of maybe being an early sign of dementia. Sometimes hearing loss can cause symptoms of dementia, and sometimes it can actually lead to dementia. So hearing loss being addressed can be a preventative measure. But again, thinking about the brain and the fact that it controls everything that we do, these diseases can affect all of how we communicate, how we see the world, how we, get through our day. So there are numerous diseases and conditions that can cause cognitive changes. Some are treatable, some are not. But the symptoms of all of them can be treatable. And sometimes those, again, we try to be preventative. We try to focus on non-pharmacological treatments first, whenever possible, because medications, especially as we get older, can really have some bad side effects. And so, but sometimes a person becomes so uncomfortable later in the disease process that medications can be really helpful to make that person, to help that person feel more comfortable and treat some of those side effects of their disease. So early diagnosis is important to, hopefully address treatable conditions. Again, there's a lot of preventative stuff that we can do, everything from walking to, exercise, to staying socially active, and keeping our brain active. But there are, sometimes, especially if a person has changed rapidly, like fairly suddenly, there could be something medically happening that could be treated. For example, a urinary tract infection is one of the most common ones that we start to notice significant changes in behavior and function. It doesn't kind of make sense unless you work in this field, but for whatever reason, urinary tract infections can cause significant change in cognitive, in memory and behavior. And the person may not
if I could,
recognize, that they
if I
have.
could interrupt a second, Joy,
Sure,
is that,
sure.
so urinary tract, is that the UTI in female and male or one or the other?
It could be in both, male and female. It's more common in females, but men can have that too. And it can also, kind of cause these changes for the person.
Thank you.
Good question. Thank you. All right. So probably, for those of you who work in this, you've seen this slide. This is from the Alzheimer's Association. It just is a way to try to help understand that dementia term is an umbrella term. This is an old slide, but I think the numbers are still accurate, that Alzheimer's affects the majority of people with dementia. Vascular disease, Lewy bodies, and frontotemporal dementia are reflected in fewer people. But all of these conditions are, all of these diseases are causing the symptoms of dementia in the person, okay? And so you can have Alzheimer's and that can cause dementia. The tricky thing is you can have a couple of these. You can have Alzheimer's and vascular disease, and that's causing your dementia, or you can have Alzheimer's and Lewy body. And so many people do have a number of these diseases that are contributing to dementia. And then I made this slide this morning just to try to help, because a lot of people, even when I show this slide, they say, oh, okay, I'm still confused. But if you have Alzheimer's, you have dementia, but you could have dementia and not have Alzheimer's. So just like with ice cream, okay, ice cream is the umbrella term. And all these different flavors are the ice creams, that are under them. So if you are chocolate ice cream, well, you're still ice cream, but you can be ice cream and not be chocolate ice cream, if that makes sense. So just trying to simplify that. Anyway, any questions on that? Okay. So in dementia can impair everything to judgment, making decisions, kind of, solving problems, and thinking about risks. And that's where we start to, have to begin stepping in, trying to, provide alternative options. So if, for example, somebody is driving and getting lost, that's a big one. And it can be really hard. I mean, driving is our independence. So being, told that we can no longer drive is one of the worst things that can happen to us, right? And so it's a really hard decision that has to be made. Some people make that decision for themselves. I had a woman who was starting to open, she said she was opening her door to see where the yellow line was while she was driving. And at that moment, she said she decided that she better stop driving. And so sometimes people kind of can recognize it themselves, but many times due to these disease processes, the person is not able to have the insight to recognize that they can no longer do certain things. So judgment, kind of puts us at risk. And what do we do for that person who can't drive? Well, we bring in alternatives. We try to make sure they're still getting everything they need. And I look at RSVP as being a really great alternative with the volunteer program. So thanks for I need to say this, RSVP is one of my favorite nonprofits in our community, and so appreciate the work that they do. All right, dementia also impairs attention, perception, the ability to stay on task and concentrate, and reasoning. So our ability to, again, recognize risk. All right. So also organization, so kind of planning and initiating and following through with an activity. Many folks that I talk to, the caregiver says he just sits there, he doesn't do anything. And they might be recognizing that, you know, his or her memory is also changing. And so they want to keep the person engaged and active mentally and socially, to hopefully maintain their function. But sometimes people just have something called apathy, where they just don't have that drive to do those things anymore. And so, you know, trying to figure out how to support them through that, having setting up routines and that type of thing is helpful. Memory is the one we think about the most often. With Alzheimer's disease, short-term memory is what is lost first. But those other diseases, frontotemporal dementia, is one example that doesn't affect memory first, and so it's frequently misdiagnosed. It changes the person's personality and judgment. So they lose that ability to have empathy for others and just become a different person. And the memory loss comes later. Communication, of course, is affected. And so for some folks, depending on, again, what kind of disease process they have going on, they may lose words, they may use the wrong words, they may really have some significant speech impairments, or they may have comprehension difficulties. So you may be talking and they may be only catching every fourth word and just really not understanding what you're trying to say. And then abstract thinking, just that, you know, for my mother-in-law who had vascular dementia, I always, we noticed that her humor, her ability to kind of catch sarcasm and those type of things changed. And she was no longer able to, you know, kind of think the way she had before and to understand when we were being sarcastic. All right, so here's again that list of diseases that cause dementia. Alzheimer's starts in the hippocampus, which is a part of the brain. There's 2 of them in our brain, and they look like seahorses, which is where the name comes from. But they cause short-term memory loss to start. And then over time, it continues to affect the entire brain, and it does cause death. So that is a terminal condition. Some people live 8 to 10 years. Some people can live longer than that, and then others can, you know, have a shorter time period. So it's just hard to know how long it's going to last, but it affects a lot of people. Vascular dementia, we think about with strokes and a reduction in oxygen and blood flow in the brain. And, you know, probably the best treatment, a lot of people with vascular dementia do go on those statins to kind of, you know, help to try to keep that blood flow and oxygen flowing to the brain. For these folks, it's going to depend on what part of the brain has been affected. So if a person's had a stroke in the front part of their brain, they're going to seem kind of similar to a person with frontotemporal dementia, because that's what part of the brain is affected. Lewy body is in the Parkinson's family. People have tremors, rigid movements, falls. This one is hard because of the visual hallucinations. And so frequently they see animals and people and, you know, children that aren't there. And so sometimes they're not scary, but the scary ones are particularly difficult. In my work with people with dementia, I always ask at some point if they see things that other people don't see. So that might be, for those social workers out there, a way to kind of, you know, find that out. And then just to have them describe them. If it's something that's scary, you might get that person kind of moved to another area, or you might, let's say there's something standing in the corner like a light, and they think that's a person and they're scared of that. well, get rid of that lamp or cover it. The other thing, I had a gentleman who was seeing faces in his couch, and the couch was covered in big flowers. And so I could see what he was seeing, and it was scary to him. So we just covered it with a blanket that didn't have the pattern on it. So there's lots of different things that we can do. Once we understand these disease processes, and once we pay attention to what the person is saying and communicating with us, to try to step in and resolve the fear or the anxiety, what's causing the anxiety. Okay, frontotemporal does affect people who are in their 50s, definitely more common under age 65. And then there's also Korsakoff-Wernicke's, which is alcohol-related dementia. We do see quite a few of those folks as well. Whoops. All right. How are we doing on questions? We good? Trying to get to the other stuff in case this is repetitive for people, but there are generally 3 stages that we think about. If you go to the onto websites, there's 7 stages that some places have kind of laid out, but I tend to find it easier just to think of them as 3 stages. So we have early, which here we see word finding changes, maybe difficulty remembering names of close family members. I always point out, and Mike and I were talking prior to the session about it's normal to have more trouble coming up with names as we get older, but it's really the closer, family members. If you're forgetting your grandchildren's names and you see them all the time, well, that might be a warning sign. Starting to have trouble with familiar tasks, forgetting material recently learned. There again, as we age, it is harder for us to learn new information, and we do have to repeat more often, maybe write it down. But again, if it's starting to affect our daily life, that could be a concern. Misplacing objects. And, I have one lady that I'm working with right now who believes paranoia can be a piece of this, because she is not remembering that she's writing something and then later she finds it and she believes somebody else has written it or somebody has moved something. And so that's in that early phase, we can develop those kind of paranoias because of that. Middle stage is, forgetting our personal history, maybe becoming more moody, withdrawn, starting to choose the wrong clothing for the weather because the person may not be recognizing that it's cold out or hot out, and they're losing track of, the time and paying attention to the calendar and even understanding what that means. So middle stage is definitely where people are going to need more support from caregivers, from people like you all in the community. And then this is where it's also important to really be dementia friendly, to have an understanding of what this person needs, and as we support them. So they're still able to do certain things, but maybe starting to need some help with bathing and, so we call them ADLs or IADLs, definitely going to need some help with bill paying and things like that in the community. And then late stage, most folks with late stage are going to need hospice care. Something that we often forget is that these are terminal diseases for the most part. And so we need to bring in palliative care or hospice care and pay attention to when there are changes within, the person becoming incontinent, coughing more because maybe they're having trouble swallowing, So these folks definitely require 24-hour care that could be in the home with additional support. But yeah, definitely having those needs. So I'm going to quickly go through this, but we all have core needs to feel useful, to care for ourselves and others, to give and receive love, and to feel good about ourselves, and to make choices, right? So as people decline in their disease process, they might need more help. But it's important to always remember these needs and try to figure out if we can meet those needs. So I love an example of a gentleman with Alzheimer's who was unable to leave his daughter's apartment anymore because he couldn't walk. And she discovered that he was a worker, a very hard worker. And so she got the packing bubbles that you get in your Amazon packages, or that you as a kid used to walk on. Maybe we did. We loved to run all over those packing bubbles and pop them. Well, she was able to tell him that it was a necessary job and that he was getting paid for each of those sheets if he would pop those. So it kept him actively engaged, it kept his fingers working, and he felt useful. And that was, just really made him happy. At one point, he asked her, is this really worth it? And she thought that maybe he was on to her, that she was telling what we call a loving lie. And instead, she found out that he just thought he needed a raise. So he asked for a raise, and she went and asked the company for a raise, and he got that. So sometimes we do these things because, and this is hard for family members to lie to their loved one, but sometimes for comfort care, for compassionate care, we do make these kind of lies. So meet those needs to be useful, and to make choices. That person may have trouble if they have too many options, but simplify those options down to two things. So, do you want to wear the blue shirt or the red shirt, to kind of meet those core needs? And really focus on the skills that are retained. So another thing that I do as part of my assessment is trying to find what's still working in that person's brain, what's still working for them. This could fluctuate. This could be better in the morning and really, they decompensate later in the day. But yeah, figuring out, okay, what's still working? Is that person still able to read? And if so, if they're having trouble comprehending what I'm saying, if I write something, that may help them to understand. If they are still able to write, if they are still able to draw. So finding those strengths and celebrating those. These are definitely skills that are retained as the emotional memory. So you've probably all heard the phrase, they won't remember what you said, but they'll remember how you made them feel. And that's for all of us, but especially as we start losing our memory later in the disease process, this isn't so much true because, everything is being forgotten. But definitely in the middle stages, we need to really, focus on how are we building rapport and how are we making them feel in our presence, right? So enjoying music, oh my gosh, there's been so much research about music and the brain. So always try to ask about music, what that person likes. This goes late into the disease process and has been shown and proven to really kind of excite parts of the brain, because music is stored everywhere in the brain and can actually help that person function better when it's music specific to their liking, during that period of, when you're playing that music. Humor can be kept. We have to find things to laugh about. touch, of course, is super important, but, paying attention to the nonverbal communication, of course, asking permission to touch, and then recognizing that for some people, touch, can cause discomfort. So, it has to be very person-centered. And then spirituality, if that person went to church as a child, if religion was important, those things oftentimes can really be helpful in bringing back those old memories. So we think of behaviors as communication. Always think of, it's not this person giving us a hard time, it's this person is having a hard time. And that person is trying to communicate an unmet need. If we can look at it like that and kind of flip our narrative, instead of saying, this is a problem person, it's like, no, this is a person with a disease. What are they trying to say? So these are just some of the challenges. I've already talked about a lot of these. Repetitive questions can be very challenging for caregivers. So, I always talk about what are you using for like a communication area to try to help with that? For example, a whiteboard, a calendar, where you write, oh, we're having pot roast for dinner. If that person has been asking, repeatedly for the past 15 minutes, what are we having for dinner? That might be a thought, but it has to be presented in a really positive way. And, not as, I'm so sick of you asking me that. Instead, we need to make that really a positive, like, I think this would help me if we had a whiteboard and a calendar. So setting up that communication area. When it comes to planning for crisis, having that communication area, and usually we think of the refrigerator, I think is so important, to have that information be available on the computer, on the refrigerator. And that's where you can keep the file of life and the first responder tool that we're going to be talking about. And so, I think that can be super helpful. All right. So we've talked about this. Wandering is a big issue for sure. Elopement. Many times I visit families and people with dementia in their homes, and they're looking for their home. And their loved one will say, you are home. We've lived here for 45 years. I'm not sure. I think what's happening, we won't know for sure, is they're looking for familiarity. They're looking for security and safety. And so what we can do is not argue with them about, you are home, this is your home, and not trying to prove it to them. Instead, just to reassure them, there's no place like home, is something I frequently say. And, what do you miss about home? Getting them talking about that. So you can kind of try to figure out what they're seeking. Sorry, to go back to wandering, with the GPS devices, there's a lot of technology that can be super helpful. If you are a caregiver, definitely connect with your case managers, your ADRCs, your dementia care specialists, to kind of find out different types of devices that can be helpful to keep that person safe. All right. And then they can become verbally abusive, paranoia, we talked about, hallucinations, resistance to care can be really challenging. And so there's books and articles, and, this is a really big subject. So it's kind of finding out, if you are a caregiver, talking with a specialist to address your specific needs. All right. So, as in addition to meeting the emotional needs, we need to try to meet the physical needs. Fortunately, doctors and facilities and people who care for people with dementia are starting to recognize that we need to address pain. I'm in my 50s now and I have pain. So I can't imagine what I'm going to have when I'm in my 80s. So even just having a routine Tylenol or pain medication on board has been shown to reduce some of the behavioral challenges that we experience. But yeah, if a person again is doing something, they may not appear like this gentleman looks like he's in pain. With dementia, it can affect those connections in the brain, and so they may not even know they're in pain. They may not be showing it even in their nonverbal communication, but it may still be a benefit to ask the doctor about getting on some routine pain medicine. All right, so we want to also think about nutrition, hydration. People are frequently forgetting to eat, forgetting to drink. And so a lot of times then that results in some of these more challenging behaviors. Constipation is another big issue. And so, when was the last time that person had a bowel movement? And is that causing some of these behaviors? And then, get people out if you can, get them exercising and moving. Lots of research on exercise really helping with function. So even if you already have dementia, getting moving is going to help your brain function better. You're going to want to, address those fears, pay attention to, what's causing that fear. It could be a reflection in the window or a mirror that needs to be covered up because that person later in the day believes that person in the mirror is somebody else. And so we have to observe first to be able to figure out, okay, what's causing this? And there's an old saying, but be a detective, not a law enforcement, not a cop, right? So try to be the detective to figure out what's causing this rather than, oh my gosh, this person is doing this to me. Empathizing and validating the person's feelings is always where we start when building rapport. So if we listen and if we empathize and we validate and we don't argue and we don't try to reason, we're going to get so much farther with these folks. So nonverbal, I can't speak to this enough, but I think we need to pay close attention to our nonverbal communication. I think a lot of times for family members, particularly if there's something hard that they have to talk about with their loved one, it shows in their nonverbal communication. And so then that person, and especially I've seen this with people with dementia, is that as they're losing their communication skills, they're even paying closer attention to our nonverbal communication. So we need to approach in a relaxed, calm way with a smile and with a slow approach. So all the things that we have taught with Dementia Friendly, if you've gone through those kinds of trainings. So yeah, what are they saying with their body and their face as well? So you have to, in addition to, taking a big breath before you go in, and being calm and being positive, again, you need to also pay attention to their body language. How we approach is so important. Try to focus on the positive, the strengths instead of the weaknesses. Always approach from the front, recognizing that as we age, we lose our peripheral vision and our sometimes our depth perception as well. Be at their level. Either sit with them, try not to tower over the person. And speak before so you have their attention before you enter into their space. Offer a hand or a handshake. That to me has been, is so helpful. We're making that connection, making that situation seem normal because it is normal. We're, two people coming together, talking to each other. And that helps that person really focus to have that touch. If it's a situation where it's, the person is upset and you're not going to do that. You have to trust your judgment and again, pay attention to what they're communicating non-verbally. But most of the time, if we reach out a hand, they're going to take it. Gentlemen especially seem to, feel that respect when it's a firm handshake. All right, we probably don't have time for bathing. Like I mentioned, there's a lot of books written about this. So there's a lot of ways to set that up to try to reduce having challenging behaviors that come from that. All right. So in addition, family members, we need to really focus on their needs as well. Recognize that people have something called ambiguous loss, where they're kind of losing that person bit by bit, or maybe some anticipatory loss, kind of imagining what's going to, be what it's going to be like when that person does die. There's a lot of guilt. There's a lot of feelings. So try to get those folks talking to each other, connecting to resources. And yeah, know that their feelings are okay. I think being able to verbalize, like sometimes, I have family members who will sometimes say, I just wish this was over and I feel really guilty about that. But helping them talk through that, because that's a very normal feeling, and letting them know that it is normal. All right, so when it comes to rainy day planning, here in Dane County, we had a big discussion, kind of came together, brought some of the entities together to talk about what's the best way to provide information to the first responders and case managers or whoever else might come into a home of an individual who has dementia and is in need of support. So we decided that the file of life has been around. Everybody in Dane County, for the most part, seems to know what it is. So we use that piece. Appreciate those partners who provide that to community members. The ADRCs definitely provide those file of life documents. And on that, it's emergency contacts, doctor information, medication, etc. And then in addition to that, we came up with a first responder tool for people with dementia. And so the information on this tool should be, can they be left alone? So these are some of the additional things, and what comforts and what soothes them and what upsets them. So I think those are kind of the big areas. These documents can be found. Either you can go online and get the file of life. You can order that yourself. During COVID, they were providing them free. I don't know if they still are. But you can also call the ADRC and ask for one to be mailed to you. Again, they have magnets and you can put them on the refrigerator. In addition to that, if your loved one has dementia, you can fill out a first responder tool safety plan. And that is available on our website, or you can call me and I can email one to you. And on this first responder tool, you're going to want to have some general information, like I said, if they can be left alone. And then probably one of the biggest things is who they can contact, who the first responder can contact if the person can't provide that information. How they communicate best. And then also those sensory aids like glasses, hearing aids, what's going to be helpful. I have a Squishmallow on here because I love Squishmallows. But for some people, having that comfort item and thinking about addressing sensory needs is super important. So this is an image of the first responder tool. And again, it's got the language that they understand. That we do ask about weapons in the home, allergies, and again, do I wander can I be left alone? And then here, this big area where you can talk about other specifics that would be helpful. One thing I've learned in this role with crisis work is that people are people. You can have a person with dementia who also, has some sensory issues, maybe similar to a person with autism. And so thinking about what could be helpful for a person with autism sometimes can help us with a person with dementia. For example, again, the squishmallows or a weighted blanket or, a pad that kind of sits on their lap. So thinking about what soothes us during periods of crises, what soothes us when we're upset. At times it's a rocking chair. I don't think as many people have rocking chairs as they once did, but there were studies done on people who, facilities, nursing homes who provided rocking chairs, and the reduction in agitation and aggressive behaviors in those individuals. So using, and there's so many products out there. There's little barking dogs that are like robots that I have a lady with dementia who just adores, and so many people do. Baby dolls, there are therapy dolls that can be really comforting. So use those kind of tools when thinking about how to support that person. And then you're going to want to fill these things out and then update them on a routine basis. So maybe it's when you change your batteries in your smoke detectors, you kind of check on, okay, are we up to date in this information? Do we have our advanced directives? Can't stress enough the importance of having power of attorney documents, both for healthcare and for finances, having those in place, making sure your doctor has those. Like I mentioned, we keep this information on the refrigerator because that's where case managers or EMS workers, et cetera, are going to look for it if they come in a crisis situation. You can also provide that to the mental health officers or to the local police. So that would be a conversation that you could consider if it's, likely that police will be involved because this person is having some aggressive behavior, just to kind of give them a heads up that this person has dementia and this is what works for them. What the officers frequently want are hooks and triggers. So the hooks are, let's say the person loves to talk about the Green Bay Packers. Well, that's the hook. And then this person is, we don't talk about, I don't know, politics, because that's a trigger, right? And so just kind of working with either your local case manager, dementia care specialist, the ADRC, and kind of addressing, is that necessary? It isn't for all people to share that information with police ahead of time, but sometimes it can be helpful. We do, of course, need to get permissions from the person or the decision maker about doing that.
Now, Joy,
Yep.
we had a mental health officer from MP Madison Police Department a couple of years ago, and he was requesting that people who have situations like this, it makes a lot of difference if they can be reviewing the file for that location with that person in advance of getting there. I mean, it's a crucial few minutes that can really make a difference in the person's outcome.
Right. Yep. Yeah. And again, we work pretty closely with the mental health officers. More police forces are starting to have social workers and embedded mental health workers, kind of on their team. So that's awesome. Because, yeah, not all of these situations, even if that person is becoming violent, we definitely don't want a person with dementia ending up in the jail, right? And so fortunately here in Wisconsin, we receive, I think that as we were talking about earlier, the police get a lot of education And so they're always really trying to work with families to figure out alternatives and get that person connected to resources. But it can be, yeah, real challenging. And so, with this information, we'll have better outcomes, and, probably be able to, provide assistance without, a full-blown crisis needing to happen.
Okay.
Something that our ADRCs are providing is these ready-to-go bags, like for the hospital. So that's a suggestion. And then here is the contact information. Do we have other questions in the chat, or anybody else have some questions?
There are questions in the chat, Joy, if you take a look at that real quick.
Okay. Let's see, I'm going to stop sharing. I can ramble, so I apologize, and it's hard to, rein me in. So what are some mental or physiological illnesses that dementia is mistaken for? And how do you differentiate dementia from other conditions? Yeah. So medical doctors are the best at, trying to differentiate that. But even our specialists, our psychiatrists who work in this all the time, sometimes I'll have a family member who's had a loved one go in and they can't give the definitive diagnosis for a year. Some of the physiological illnesses, somebody could have fallen and have a brain bleed, for example, or maybe they have a tumor in their brain, and that can sometimes be mistaken as dementia. And so sometimes that has been the best tool that I've had in my toolbox when talking with someone who doesn't want to get tested, because my mom had dementia and I don't want to know if I have dementia, they'll say. And it's like, well, it really could be something else, and it could be something that's treatable. It could be, again, dehydration, thyroid imbalances. It could be, other kind of imbalances in terms of, vitamin deficiencies. Okay. And so, it could be that they also have a bit of dementia as well. But once those physical conditions are treated, a lot of the abilities can be returned, right? If somebody has alcohol dementia, can they get better if they give up alcohol? That's a really good question, and that's a hard one. It depends, of course, depends on how much, they drank, and how soon after. I think we're seeing a lot of older adults who are starting to have more addiction issues and challenges with alcohol, but maybe they didn't start until they were 65 after they retired, really starting to have a problem with alcohol. And then let's say they are able to quit in a few years. They're going to have better odds, right, of having some return. We can grow new brain cells throughout our life. With alcohol dementia, it's been shown that it's a thiamine deficiency frequently. So there can sometimes be some additional treatment. So I've definitely seen some folks who, really became incompetent, incapacitated due to their dementia. And once they stop, become competent again. So again, it's just really going to depend on the person. All right, let's see. How disruptive are physical changes, perhaps decor in the home with those with dementia? Again, it's going to depend on the situation. I'm not sure what you're referring to there. But, for some people, it really helps to kind of minimize clutter and to try to, change out some things. If it was like I gave the example of the couch, and just putting a blanket over it, I guess I would err on the side of going slowly. doing things slowly, right? Only making one change at a time, trying to get their permission. It's a real balance because, you know, you could have a person who's got a hoarded situation and it's really unsafe and they're really unwilling to kind of address that issue and recognize that's a problem. And you might be able to, you know, talk with them about that, or you might be able to remove some things slowly without them becoming upset. But the flip side of that is you can also have a person who is starting to have paranoia because things are going missing. And so you really have to gauge that and try to, you know, talk with them about it first. But yeah, I would just suggest going slowly with that.
How do you get a person to you know, get their approval? You know, say you want to change the paint color in the house. You know, how do you go about doing that? I mean, some people just may be totally resistant to that, or the color drives them crazy. You know,
Yeah. Yeah,
how
that's
can you do that?
right. That's a good question. My suggestion, especially if you're starting to deal with some other challenges, is choose your battles. Just like, you know, think about, is this really important? Why is this important? If this person is really going to be bothered by this, unless it's a life or death or a safety challenge, let's just let that be. And yeah, don't make that change, right? So you know, whenever somebody is doing something, I always give the example. I was in a facility and there were some men moving tables around and they weren't even talking, but they were kind of non-verbally communicating to each other and they were just moving tables around and they felt really good about it and it was purposeful. So one of my mantras is purposeful activity. If it's not hurting anything, if they're putting stuff in the wrong cupboards, but they're feeling good about it, maybe look at, okay, you know, I just need to accept that. So, and that's a process. And that's why you need support to be able to do that. So, all right. Thanks for listening to me talk today. My contact information is here. I'm always happy to talk through situations. I work, as I said, with Adult Protective Services just here in Dade County. I can come out and see folks. You can email me or call me directly. But that said, I sometimes can't respond as quickly because I am one person currently in the county doing this. Sometimes it's best just to go to the APS line if there's any question that there's abuse, neglect, that's going to always go through the APS helpline. And then they might bring me in as an additional support, but I cannot look into financial exploitation, et cetera. So, but if there's behavioral challenges supporting the family, that type of thing, I can help with that. Okay.
Any last questions for Joy? Okay, then. So, Joy, thank you so much. This has been a really informative hour for us, for me at least. Yeah, I
Good,
learned
good. A
so
lot of
much.
info. Thank you. Good to see people that I recognize and have a good day, everybody.
Thank you, everyone, for joining.
Thanks, Mike.
Thank you.